Today I'm presenting a case of acute non-rheumatic streptococcal pharyngitis-associated myopericarditis, or SPAM, mimicking a STEMI in a young adult male. The objectives of this presentation are to recognize a case of SPAM presenting as a STEMI mimic and to differentiate the diagnosis and treatment of SPAM from acute rheumatic fever with a focus on the structures involved in rheumatic heart disease. For our case, a 30-year-old male presented to the clinic with severe substernal chest pain radiating to his arms. This was preceded by a confirmed Group A strep pharyngitis 6 days prior to the onset of his chest pain. He had received 1 dose of penicillin with improvement of pharyngitis, but noted 2 days of non-migratory polyarthralgias prior to presentation. Exam was only notable for tachycardia and visible discomfort, and as you can see in Figure 1, the EKG in the clinic showed ST elevations in the inferior and lateral leads concerning for a STEMI, so the patient was admitted for emergent coronary angiography. Coronary angiography and echocardiogram were normal, and labs were notable for elevated troponin with a significant delta as well as elevated inflammatory markers. Based on the latency from pharyngitis to chest pain, lack of valvular involvement, and confirmed Group A strep infection, he was diagnosed with acute non-rheumatic SPAM. We differentiated this from acute rheumatic fever using the time course of the illness and the revised Jones criteria. To diagnose initial acute rheumatic fever, you need 2 major criteria, or 1 major and 2 minor criteria. Our patient had 2 minor criteria with polyarthralgias and elevated ESR, but his myocarditis did not qualify as a major criterion and he could not be diagnosed with rheumatic fever. In the 2015 AHA statement on the revised Jones criteria, they defined carditis as a valvulitis involving mitral or aortic insufficiency, stating that isolated myopericarditis is rarely rheumatic in origin. To summarize, SPAM is a treatable STEMI mimic that presents with chest pain, focal ST elevations, and elevated cardiac biomarkers 2 to 7 days after strep pharyngitis in young adult males. This latency period of 2 to 7 days is shorter than the latency period of 2 to 3 weeks in acute rheumatic fever. Cardiac imaging shows a focal myopericarditis in SPAM, while acute rheumatic fever has a valvulitis involving the mitral or aortic valve. These conditions are important to differentiate because SPAM resolves with antibiotic treatment for pharyngitis, while acute rheumatic fever can require long-term secondary antibiotic prophylaxis. The take-home points of this case are really to focus on the shorter latency period in imaging findings of focal myopericarditis without valvulitis when differentiating SPAM from acute rheumatic fever. The diagnosis is rare, but important to consider as its treatment differs from both acute rheumatic fever and other causes of myocarditis and pericarditis.